Okay, so welcome everyone on board. Um, in last few days, like it's almost been a week. We are just trying to have a quick review of anesthesia, and every day I'm just trying to cover one of the unit so that the exam candidates can have a quick review of the system, and then they can explore the further knowledge points and further dig out the topics in detail. Yeah, but the basic purpose for me to have a discussion of every day one unit is that you can just grab the overview, okay? And usually in the exam, the reason for failure is not that you don't read about it. The reason is that you are not able to compile the answer. And why you are not able to compile? Because anesthesia is such a vast subject that you are as if you are sitting on a roller coaster. And in even in one scenario, you need to have such a broaden knowledge that if you are not able to compile your answer, unfortunately, especially in table viva, or you can say short cases, you will not be able to to have a good answer in quick time. Okay, so yesterday we just discussed respiratory, cardiovascular system. So in similar way, we will try to have a view that how what are the things to learn when we are preparing respiratory system. Okay, so respiratory system actually, just like we discussed yesterday, we will be so actually the major portion here is lungs, but if you just have a look, there is one portion of airway. Okay, and then you can say this is lower respiratory tract and this is upper respiratory tract. Okay, and something very important is heart. Okay, so any problem not related to heart can also create problem in the lungs. Okay, and similarly, problem not related to respiratory tract system as at all can create problem in the even in upper respiratory tract tract or lower respiratory tract is one of them. The highest yield point will be either foreign body. Okay, and one of other will be any anaphylaxis or any allergic reaction. So it has nothing to do with a respiratory system, but it will directly affect respiratory system. Okay. So either it is upper airway and or it is lower airway. So today's discussion will be mainly on the lower respiratory tract, or you can say lungs. But if you want to have a good concept, you should know that how all the things will affect. So usually for the example for this is, for example, if you have an upper airway tract obstruction, it can cause negative pressure pulmonary edema. Okay, so this is, you can say, it has nothing to do with lower respiratory tract. Lungs are absolutely fine and virgin, but it can create big problem. Rather, as good the body is, as strong the body is, there will be more chances of development of negative pressure pulmonary edema. So this is one example of having effect on the lungs from something not related to lungs actually. Okay, so this is one example. So you should be knowing the effects of problem with heart, like we discussed yesterday, that all the valvular heart disease and heart failure can affect the respiratory. So I will just not go I will in detail. So if you want to just have a look, so some of the respiratory symptoms are, like you can say, shortness of breath. Okay, so mainly sometimes you are not able to identify whether this is of cardiac origin or if it is of respiratory origin. But usually the respiratory origin will have more chances of having cough and sputum, more chances. I'm not saying that cardiac cannot have, but there will be more chances of cough and sputum, and there will be more chances of having some infective sign. Okay, infective, or you can say like septic signs, or you can say some fever. Okay, and if so, there will be more chances if the shortness of breath is of respiratory origin to have these symptoms. So this will give you an insight that the probable cause is the respiratory one. Plus, there may be association with some allergies. Okay, another more important thing here will be smoking is one of the biggest factor for respiratory problems. Okay, and the lungs, and then there may be some hereditary problems, or you can say genetic problems. One of, like you can say cystic fibrosis. Okay, or things like that. So you should be, when you are taking history, so the same shortness of breath, there will be certain things which will make you identify towards that. Similarly, there will be some, of course, the respective signs also. Okay, and then you will go towards the investigation. But usually, this will be the story. Okay, so certain diseases which are very common. One of them, for example, is asthma. And asthma is not 100% related. It can occur without, but it's also sort of, some of things are common, is COPD. Okay. Then there is restrictive lung diseases, like, for example, interstitial lung disease or things like that. Or there are certain systemic disease which react or represent in the form, like, for example, rheumatoid arthritis. Rheumatoid arthritis can present him having a restrictive lung disease pattern. Similarly, if there is some other autoimmune disease, they can also present as restrictive lung disease pattern. So these are certain things. Then like any other, in any other place, there may be carcinoma. So here the carcinoma is a separate entity, but it will also present having respiratory infection or respiratory symptoms. But there will be certain more chances of, for example, hemoptysis. Okay. And there will be certain factors which will be more associated, like weight loss. Okay. And other some risk factors. Okay. So, but whenever you are evaluating a patient with probable respiratory symptoms, these things should be in your mind, that either it is some allergic symptoms, either it is some infective symptoms, either it is carcinoma, either it is because of some cardiac problem and the respiratory problem is secondary to the respiratory system. So if you want to understand in a nice way, you should be thinking, and whenever you are evaluating, especially in long cases, or people working in ICU, or people, any question related to acute medicine, your approach should be in that way. Okay, because otherwise you will not be able to. So you this and there are some infective causes. One of them, the most common in Pakistan, in our part of world, is tuberculosis. So tuberculosis is very common and it's frequently asked in the exam. So in not only because of the disease pattern or disease pathology, whatever is there is a, like you can say, it's a like it's a infective disease. It has high incidence of like infect in occupational hazard. In addition to that, the medication which the tuberculosis patient will be taking has multisystemic effects, and they can affect the conduct of anesthesia, especially with reference to liver dysfunction or neurological problems or things like that. So whenever you are evaluating, so these are some important things. Now, some points about the examination. So some of the important point with reference to examination are, for example, one of them is wheezing. So you should be knowing what is difference between wheezing and rhonchi. So same thing, which if you are auscultating, it will become rhonchi, and the audible bronchospasm is evident with in the form of wheezing. Okay, so this is one thing you should be knowing. Then signs of respiratory distress. Respiratory distress. So either it is upper respiratory tract, upper respiratory problem or lower respiratory problem. There will be some specific symptoms, sorry, specific signs which will be showing that patient is in respiratory distress. Okay, so like in the supraclavicular area, the pursing of the lips, patient is cyanotic, patient is sweating, patient is having irritable. Okay, so all these things will be like use of accessory muscles. So all this flaring of the nasal bridge. Okay, so all these things will be showing that the patient is in respiratory distress. So whenever you are examining the patient, you should be clearly understanding that are there any signs of respiratory distress, or there is some wheezing, rhonchi, or also the crepitations. Okay, crepitation can be of cardiac cause, but here there is a little bit different, but the same creps can occur in both, whether it is respiratory cause or cardiac cause. So then you need to do in some problems, if there is some fluid is there, so percussion node will be dull. Okay, And if, for example, pneumothorax, it will be hyperresident. So these are basic things you which all know, but I'm just giving you a quick review that how you. So the last but not the least is the auscultation. You will be finding any added sounds like any. And another important thing is that strider, okay, and conducting sounds. Sometimes people easily uh, confuse it with some spasm or some obstruction. But remember one thing, that wheezing is having whistling sound. Okay, so you should be very clear about what wheezing is. Usually, in majority of times, it is the conducting sound transmitted from the upper respiratory tract. It's not wheezing, but unfortunately, we pick it as wheezing. So it's very important to clear the airway or ask, like you should be knowing how to differentiate between clear wheezing or any respiratory distress with only conducting sound. Because if there are secretions in upper airway or anything, it can you can easily misjudge it as some sign of obstruction. Okay, so you should be clearly knowing what you are doing. Then like okay, so now moving on to like investigations. So investigations, I'm just giving you an overview. There may be something which I miss. I will be very happy if you can just mention in chat box if I have missed any important point or important thing which you think should be here in our discussion. I will be very happy. Just drop a message on the chat box. So usually chest X-ray is one of them. Okay, ABGs is one of them, and this one. There are certain tests for pulmonary function test. One of them is the proper spirometry, and one of them is the bedside in the form of when we are evaluating the responsiveness. So there is a one bedside also which we do, type 1 and type. Yes, I'm just going towards that. I'm just going towards that. So whatever investigation we are doing, actually we have to see that there is problem with the gaseous exchange. Okay, there is one thing which we have to understand, that is there any problem in the gaseous exchange. Okay, is there any problem in the mechanical problems, like mechanical problems. And the third thing is coordination with the heart, the big brother. Okay, so these are the three things, and actually I have made it in a different word, but it is the same three-legged tool which we do it in thoracic surgery. So gaseous exchange, where the gas is exchanged, if there is any problem over there, there will be some things which you can get. Like, for example, if there is fluid over there, if there is any problem in which the blood flow or the air flow is problem, so gaseous exchange will be disturbed. Okay, any damage to the membrane, any problem with the surfactant, which occurs in either it is asthma, if it is COPD, or it is any other condition, pulmonary edema. So in whatever the reason, there will be problem in the gaseous exchange. So gaseous exchange usually not only with the clinical sign symptoms, you can identify it with ABGs. Okay, ABGs, and another yes, lung parameters. Another thing which with which you will be understand picking it is BF ratio. How good is your business going on? That how much FiO2 you patient is receiving? Patient is on air, or patient is with nasal cannula, or patient is with face mask, or patient is with face mask with reservoir bag, or the patient is with venturi mask. Whatever the source of oxygen therapy, nasal cannula will be the minimum, then face mask, then non-rebreathing, and then if next step will be that patient is on, for example, CPAP or BiPAP. And the next, of course, will be the patient is intubated and non-ventilated. Whatever the source is, you are thinking that how good is your business going on, how much oxygen you are giving, and how much PO2 you are achieving. Okay, so this is one way you can understand about the oxygenation, like gaseous exchange. Mechanical factors. So mechanical factors occurs with this pulmonary function test. So there are lung volumes and capacities, which we do, like tidal volume, inspiratory reserve volume, okay, expiratory reserve volume, residual volume, and the most important thing for anesthetist miskin is FRs, because functional residual capacity is the store when we make the patient apneic. So our business, our importance is not tidal volume or inspiratory result volume or expiratory result volume alone. Our business end is the concept of FRC. Okay, because if FRC is reduced, our, you can say, if we don't receive our salary, how much is in our bank is the one which we can use in the time when we are not receiving any salary. So this is our saving. So this is our fixed deposit what we have in our account when we have any problem. So FRC is our business end. So any cause, any problem, either FRC is reduced, or if you have a patient age group in which the, even in case when you don't have money, you or your family is spending like anything, so you will lose everything quickly. So it is these are the conditions in which a patient age group or patient categories in which the oxygen consumption is more, like in pregnancy, like in pediatric patients. So not only they have reduced FRC, they are wasting their or they are using their oxygen too much. So they will get apneic after apnea, they will become hypoxic early. Okay, so this is the basic concept which you will be you will be doing by this peak expiratory flow rate, which we do bedside, or the proper spirometric analysis. The basic thing which you are getting are the mechanical things. This has nothing to do with the gaseous exchange. This is something else. This is only mechanical. How much air is ballooning the lungs? Okay, how much air is ballooning the lungs is this concept. And the third one is how heart and lungs are, the two brothers are coordinating with each other. Okay. For that, you need to have a good cardiac output. You need to have a good oxygen, good hemoglobin, because hemoglobin is the one which will be going, will be taking the oxygen. You can say it is the limousine or car of oxygen to take it throughout the body, because the dissolved oxygen is very small amount. The main amount is the one carried by the hemoglobin. So if hemoglobin is not there, or in any condition like what occurs in carbon monoxide poisoning, the oxygen is there, but hemoglobin is not giving attention to the oxygen, and it is in romance with carbon monoxide. Okay. So the oxygen is not able to be carried by the hemoglobin. So this is a concept which occurs that either the heart is not pumping, or there is no transport to take the oxygen to the body. So in either of the conditions, the problem will be that the net result will be respiratory distress. Patient will be short of breath. So you should have very good concept that there are one factor which are leading for good gaseous exchange. And also one point you should be clarified over there is the VQ, the concept of VQ, that ventilation and perfusion. Okay, so you should have a very good coordination, that where the ventilation is going, there should be blood, because that's the reason that there is one concept of anatomical dead space and one concept of physiological dead space, where oxygen is going, but there is no blood to receive it. Yes, yes. Oxygen hemoglobin dissociation. Okay, so the concept of dead space is that their air is going, but there is no blood to receive. Okay, so there is no gaseous exchange. So either it is an anatomical dead space up to the respiratory bronchioles from the nose. This is the place where there is no gaseous exchange, or any place, or any place which becomes in case of any pathology. Okay, so the same mechanism will occur. Similarly, if the blood is going without oxygenation, that will also lead to what is called as shunt. So this is dead space and this is shunt. So whenever you are dealing these things, you should be having a very good concept about it. Similarly, it's that whenever you are even ventilating the patient, you should be knowing that whatever maneuver you do, you should know that dead space not it should not increase. Similarly, this is a very a very important concept, practical concept, that for example, if you have a respiratory rate of 20 with a tidal volume of 300, the minute ventilation is 6 liter. Okay. Similarly, if you have a respiratory rate of 10 and tidal volume of 600, again the minute ventilation is 6 liters, but this one is not good. Okay, and this one is good, because in every breath, you can say roughly, I'm just giving a rough idea, 150 ml is the dead space. Okay, so here the practically 20 into this minus, you go minus, only this amount is going, the alveolar ventilation. However, here, if you are giving 10 breaths, but you have giving very good breaths, good tidal volume, so you are giving at least 450 ml of alveolar ventilation. So the exact business end is 4.5 liter here and 3 liters here, though the ventilation is the same. The ventilation is the same, but the business here is nothing. You are wasting every breath, that space is lost. So this is a very important point practically, because sometimes in even in pediatric patient, it is in your mind that you need to keep a very good respiratory rate. So you are increasing the respiratory rate without looking at the tidal volume. So tidal volume is more important, with of course the pressures. So this is a concept you should never forget. Okay. So this is something which I just told you just to understand, even in the practical conduct of anesthesia or practical management, that you should know about it. That's why rapid shallow breathing index we use for the when we are weaning the patient. This is also sort of that thing, that if the patient is breathing too fast, actually, but not good tidal volume, it's not a good sign. Okay, so that's why this is the whole also this concept, the same understanding is there in the weaning as well. Okay. So now, like, I think I have given you just a concept about some of the investigation, whatever you are doing. Other tests, of course, we are giving a chest X-ray. You all know about it. What you can find any infective thing there, the hilar shadow will be increased. You might need find some consolidation or collapse or pleural effusion. You people all know about it, but you should understand the concept behind it. If there is air, pneumothorax. Like if there is pneumothorax, it was the percussion note will be, please a little light on flow volume loops. I need to prepare for it, and unfortunately today there is no time for it. Okay, I will try to have. There should be a separate session on it. In today's domain, unfortunately, I will not be able to explain to you flow volume loops, but I will tell you the importance about it. I will try. Okay. So just X-ray, some of the finding you should be knowing, and even this can occur in the talks. This can occur in the like this can this you can say that you should know how to interpret, and don't go in too much details and don't be distracted. You can start from any place and you go inside either bone, tissues, vasculature, any artifact, any lines. So you can easily describe chest X-ray if you know how the concept about it.
يوسف
Okay.
أستاذ حبيب.
Okay. So please, I will request you to mute yourself. Okay. Okay. So because we are have taken about 20 minutes. Okay. So few words about asthma and COPD. Okay. Both of them you can say are obstructive lung disease. There is obstruction and there is a problem in the expiration. So you should be knowing what asthma is and what COPD is. The basic difference is the asthma is reversible and COPD is irreversible. Number one. Number two, asthma is usually allergic cause, and asthma is having something you can say episodic, paroxysmal. There is obstruction, but some of the things are the same. There is bronchospasm in both of them. There is secretions in both of them. Okay, and of course there is shortness of breath in both of them. Okay, usually there is always a reversible component in COPD, because in COPD, whether it is chronic bronchitis or it is emphysema, okay, there is some of the reversible component which is there in both chronic bronchitis or emphysema. So whenever, like, if you have a patient with COPD, uh, one of the important thing which you should be knowing is that you will have to target the reversible component. Okay, reversible component of COPD. Okay, so whenever we are dealing, because this I'm trying to tell you the practical points as well as the important exam points which they will be asking. Of course, everyone knows how to explain the pathology of COPD or pathology of asthma. Either it is the destruction of the respiratory alveoli. Okay, so the airway is not responding nicely because of course, chronic inflammation, secretions, stasis, leading to damage of the elasticity of the lung. Same thing in a slightly different. Yes, yes, this is the difference that I just mentioned. So, the basic pathology is the same. When one there is maybe alpha one antitrypsin deficiency, the smoking, there is too much cough, sputum, and things like that. So, this is how you are approaching any patient with the obstructive lesion. And practically, important thing is that you can say this is a question which is frequently asked in the exam, that what is the differential diagnosis of hypoxia intraoperatively. Okay, so with this reference, you should be knowing that of course there may be some important things which you have to rule out. One of them is pulmonary embolism. Okay, but usually what you will do, you will give 100% oxygen. Okay, you will put the patient on hand ventilation. Okay, you will see how is the compliance, how good is the lung compliance, because if there is bronchospasm, your hands will tell you that there is bronchospasm. Okay, of course you will see any mechanical problem, in the form of any circuit disconnection or anything like that. The oxygen source, circuit, tube kinking, secretions. So you will do like that. And then, of course, patient might be breathing. So this may be a reason of patient getting hypoxia. Similarly, if there is any surgery like in which any step, like there may be some surgeries in which there is chances of embolism. So you have to be careful about that thing. Either it is air embolism or amniotic fluid embolism or pulmonary embolism. So you will be expecting that time, if hypoxia occur, you will rule out that whether anything like that occur. Okay. Similarly, another important thing with reference to laparoscopic surgery is that the airway, if the laparoscopic, the abdominal pressure is too high, patient can become hypoxic at that time. Okay. So your approach will be systematic, call for help, stop the surgeon, and you will go 100% oxygen, bilateral ventilation. And then, of course, if you will use some bronchodilators. Okay, so bronchodilators with the puffing, you can do with the circuit. You can increase the depth of anesthesia. So this is the drill which you will be doing. But the basic thing is to rule out the dangerous problems. Okay, you will be ruling out the dangerous problems, and then if it is not there, the rest of the things you can easily manage. Okay. Similarly, I was telling, and then because I'm just thinking so too much, I'm just trying to give you all the points which are important. Important point with reference to optimization of a patient going for surgery. So optimization is in the form of treating any reversible component with bronchodilators. This is one of the component. The other important thing is treating any infection with antibiotics. Okay. Incentive spirometry, because this is a question which you can easily get in the exam. Incentive spirometry, postural drainage. Okay, they can do postural drainage, then tapping of pleural effusion, pleural tap. Okay, then uh, bronchodilators, antibiotics, incentive spirometry, postural drainage. Then another, if there is concomitant congestive heart failure or cor pulmonale, they can treat with vasodilators or inotrope to improve the heart function. So these are the things, and there will be certain things which surgical things that you will try to use the maneuvers. You will try to have minimum invasive surgery. You will try to have a surgery in which you are giving very good analgesia, and they are trying to don't have you try to reduce the morbidity, my mortality, by correcting this. So there is a list of pulmonary risk factors, anesthetic factors, surgical factors, and patient factors. So you should be like, for example, low albumin level is a pulmonary risk factor. So if the patient for any good reason is low albumin, you will treat it. Okay. You will try to correct hypoalbuminemia. Okay. secretion, mucus plus diet phase. Yes. What else you are saying? Yes, it's more. Yes, it's more. Sorry, I missed it. Small smoking is very important. Treating infection, treating and with in any bronchospasm, incentive spirometry. These are the things which you can do, and there is a list of pulmonary risk factors you can find in the article. Pulmonary risk factors. You will try to target any one of them. So this is another important question which frequently being asked. So you should just try to tell you the answer. Then, of course, some of the basic stuff you should be knowing what is the mechanism of action of various bronchodilators, because there is one cholinergic pathway, okay, and one sympathomimetic pathway. So whatever medication they are giving, they are either anticholinergic or sympathomimetic. Beta 2 mediated bronchodilation or anticholinergism by ipratropium, or uh, usually nebulization is being done by ipratropium. But the problem with is it make the secretions thick, and it can cause drying of the mucosa. Okay, so that's why whenever they are using these bronchodilator, there is a N-acetylcysteine is being used, which thin out the secretion, which is mucolator sachet. Either it is done by nebulization or through NG or like oral. So N-acetylcysteine. Then there are something which are actually antihistaminics for treating any allergy component, and then the leukotriene antagonist, montelukast. So this is for maintenance of bronchodilation. Like it does not have any effect in the acute bronchospasm, but it is for the maintenance. And last but not the least is steroids. Okay, so steroids, either it is form of oral or nebulization, inhalers. Okay, so steroids is one of the most important component when you are treating any patient with asthma or COPD. Okay, uh, with the okay, so with these antihistaminic, two more thing, like one more thing is there. It's sodium cromolyn. So this is also as a mast cell stabilizer. Okay. So, like for all pharmacology, you should know the group, which group it is, what is the mechanism of action, and what are the side effects, and what are anesthesia correlation. Like if the patient is taking bronchodilator like beta 2 agonist, the what is the correlation is hypokalemia. Okay, if the patient is having repeated nebulization, be careful. You should do ABGs and you should have a look on the hypokalemia, because all these sympathomimetic, they push the potassium inside the cell. So there may be hypokalemia. So you should be taking care about it. Okay, so this is another important point. With reference to anesthesia conduct, all the medication which release histamine, you should be avoiding in both asthma or COPD. Okay, so any histamine releasing medications, you should try to avoid any medication which cause bronchospasm, which cause histamine release. You will try to, like in among the opioid, you will try to avoid morphine. Okay, you will try to use fentanyl, which is not associated with that much histamine release. So similarly, you can make a list of the medication which cause histamine release. Okay, among the induction agents, propofol and ketamine are better choice as compared to thiopentone. Okay, but remember one thing: ketamine. The problem is that it increases secretions if you are using in high dose. In low dose, there is not much significant effect. Propofol is good agent because it creates sort of, you can say, a good environment for intubation. Okay, among the inhalational agents, desflurane and isoflurane, they are airway irritant. They are actually not good choice in any patient, but in induction. But mind it, when you are using it for maintenance of anesthesia, it does not cause that much problem, because all of the inhalational agents cause dose related bronchodilation. Okay, so all of them cause bronchodilation. So there is no problem in using inhalational agents at all. Like this is not like that that you should not use inhalation agent, you should go for TIVA. It's not like that. The thiopentone, I forgot the thiopentone because it does not blunt the airway reflexes. So that's why there are chances of bronchospasm, laryngospasm during intubation. So this is the problem you should be aware, because usually thiopentone is not used frequently nowadays. Majority of people, they are using propofol. Okay. Similarly, with reference to muscle relaxant, cis-atracurium is a good choice. Atracurium release histamine, so it's not a very good choice. Tuberculin and some of the medications release histamine a lot, so they are not a good choice. In among the reversal, neostigmine and this combination, because neostigmine causes bronchospasm, it can cause increased secretion and bronchospasm. So that's why if you are using rocuronium reversed by sugammadex, that's a better choice as compared to cis-atracurium or other medication reversed by neostigmine. So this is always a good choice. Okay. Among the analgesic agents, you should try to avoid NSAID. Not all, the NSAID which is most notorious is aspirin. But usually it is said that it is better not to use NSAID if you have an active bronchospasm or the patient has a history of NSAID allergy. Okay. Otherwise, you can use paracetamol, you can use dexmedetomidine, you can use low dose of ketamine, you can use. Okay. Regional blocks, with reference to regional blocks, remember one thing, that if you have a patient with COPD, okay, and in the exam you are telling about the analgesia and you are telling epidural, or you are telling spinal, okay, or you are telling any upper limb block, okay, uh, like interscalene, any where there is involvement of phrenic nerve. So be very careful, okay, because phrenic nerve, it is blocked, because it will lead to blockade of hemidiaphragm. So patient will can become dyspneic. Similarly, if you have given a high spinal block, the same thing can occur. Patient can become, because the abdominal muscles will be blocked, and even if it is reaching up to high level, patient can become short of breath. Similarly, epidural, if you are getting the high block. So regional anesthesia, especially when you are telling, so don't forget to think that this block affect phrenic nerve or not. Okay, if you are giving interscalene block or supraclavicular block, there are too much chances of phrenic nerve involvement. If you are giving a high spinal or epidural block, there will be chances. So you should be thinking about it. Okay. Um, uh, uh, these are few of the important points which they can, because they've now I'm trying to cover up, sum up what I've told you, that they will ask what is asthma, what is COPD, what is the pathogenesis, what are the signs, what are the symptoms, how do you diagnose, what are the findings in clinical findings. They can ask you with reference to COPD, pink puffers and blue bloaters. You can explain, you will find every, but I'm telling you the concept. Then you should be knowing, you will tell that I will target the reversible component, I will optimize the patient, I will avoid the factors which can increase the problem. Then few points with reference to the ventilatory setting. Usually they say that there is slightly prolonged expiratory time. Okay. And you will try to avoid high peak pressures. Okay. High peak pressures, because if there is a there is a emphysematous bulla, it can rupture and it can cause bronchospasm. So these are two important things that you will try to maintain the ventilation without high peak pressure. So pressure control mode is a good choice because it will maintain the pressures. You can add some PEEP. Okay. So PEEP will be a good, optimal PEEP will give you a good ventilatory results. Okay. So these are the things which are important with reference to asthma and COPD. So I have just tried to give you a concept, and now you can read in detail. Okay. Okay. So auto peep is not a very good topic for me. I need to read about it. I have, so apologies for that. I don't have a very good concept. I never understand this intrinsic peep and extrinsic peep. So unfortunately, I'm not in a position to explain to you in a detail. I need to read about it. So I apologize for this concept. Okay. Uh, So some of the diseases, tuberculosis, I have told you that it's very common. It can be asked in the even in the this can question can come in the long case. In our part of world, it's very common. Okay, so important thing will be what is the pathogenesis. Okay, then they can ask you how to diagnose the sputum culture, the quantiferon test. Okay, and then they can ask you about the first line drugs and the second line drugs, how they are giving that, like rifampicin and ethambutol, or so you should be knowing the side effects. They can ask you. Usually, they have side effects affecting the liver, isoniazid and rifampicin, and they are causing liver dysfunction. So you should be knowing about it. This one has occupational hazards. You should be knowing. So you should have N95 mask for it. Okay, and then if this tuberculosis has already caused some fibrosis, so it can create problem with your mechanical ventilation. So these are the important points with reference to tuberculosis. All the question will be that how this granulomatous lesion is developed, how it is diagnosed. So it is. I will share some of the articles. I found someone asked about TB. I have downloaded some of the articles. I will share. Okay, so this is just an overview of what I could tell you extempore. I will just try to open up some of the articles so you can have a look. Asthma management. Just a second. Actually, usually these pink puffers and blue bloaters, the thing that the reason is one of them is that patient airway is because the airway is damaged. Okay, so the bronchioles or alveoli are damaged, so they are not able to have a good oxygenation, and then when during expiration it's collapsing, so they are having pursing of lip. They are fixing the scapula to and purse the lips to create, and they are trying to create a peep, actually, which prevent the collapsing of the airway. So this is one of. Then when there is chronic hypoxia, there is development of, you can say, there is like, that's why these patients have thrombocytosis. Sorry, the RBC volume is too much increase. Okay, so the hematocrit is reaching up to even 60%. So it's also important point with reference to the chances of embolism. It's a factor for it's a risk factor for thromboembolism. Okay, so this is some of the points which are there with the emphysema and chronic bronchitis. Okay. This is the classification. They can ask you the gold man classification with reference to this like FVE1 over FVC ratio and peak expiratory flow rate and response of, yes, polycythemia. Sorry, I forgot. I was using the wrong number, not thrombocytosis. It's polycythemia. Okay. So, okay. So acute management of asthma, again, it's also being asked number of times. It depends on the peak expiratory flow rate. They are doing constant nebulization with the ipratropium and bronchodilators, and then prognosis will be according to the response to in the PFR. Okay, so if PFR is improving, clinical symptoms are improving, you can even discharge the patient. Otherwise, if it is deteriorating or it is not responding, you will admit the patient. This yeah, like algorithm is there in the link. You can have a look. Okay. Mm, this is I discussed with you the hypoxia management. Okay, you can have a look here. I discussed with you. The last resort in the if nothing is working, the last resort will be ECMO. Okay, don't forget to think about it. Okay, and like you should be knowing the pathway, which are because theophylline and this aminophylline, they have been used before. Now actually they are not, because of the arrhythmias created with the aminophylline, it's not frequently used. Okay. So, effects of smoking, you should be knowing how smoking effects and what are the effects of cessation. So this is a very good that in 12 to 24 hours, clearance of carbon monoxide and nicotine level will decrease. Improvements in upper airway in 2 to 10 days. Okay, in 1 month, uh, post-operative complication will decrease. Okay, sorry, initially because it will be reactive. So and then in around 5 to 6 months, reduction in post-operative complications, reduction in lung cancer, COPD, ischemic heart disease, incredible. So these are the some of the effects. This is actually I have arranged here. This is FRCA mind maps. So these are very good source of knowledge actually. Just a second. Okay. Mm. Some of the topics which unfortunately needs preparation, and because I don't get the time to prepare myself, some of the questions which I'm not able to answer to you, apologize for that, but I have given you a broad view because I don't want to tell you something wrong. And like because I am just having a roller coaster sort of quick revision, apnea and pre-oxygenation. They can ask you what is the physiology behind pre-oxygenation. You can find some of the articles over here. Okay. And altitude and sea diving, they can ask you about it. Respiratory monitoring. So uh, I think I will stop here, and you can just review pulmonary function tests. It's written here, and also the cardiopulmonary exercise testing. They can ask you about in table viva. They can ask you in table viva about it. This is important. I have tried to discuss some of the important points which I can easily explain to you. I have tried to touch those points. Okay, pulmonary function test, FE1 over FVC ratio, obstructive versus restrictive lung disease, because in that FE1 is reduced more than FVC. Okay, so FVC is actually increased in somehow relative to the restrictive lung. Okay, uh, okay. So I will stop here, and you all are welcome to discuss. The thing is that the message for me, from me to you, is that whenever you are trying to understand any topic, you should go towards the main theme. Okay, and if you understand the main theme, then it will be like we started from the simple respiratory symptoms, how to interpret, how to have a concept about gaseous exchange and the mechanical problems and the correlation, the cardiopulmonary coordination. So these are the three basic steps. The same theory will be there with when you are dealing with asthma or COPD. The same mechanism will be there. Okay. So thanks a lot, all of you. Tomorrow, I was just thinking to have a discussion on regional anesthesia. I have discussed in detail before. Again, I tell you something. I have a lot of limitation. Even today, I had though it's a weekend, but today I had a duty. So I came back, and after that, you can understand. I'm just trying to give my maximum. It's very difficult to have a discussion every day. Okay, but I'm trying to do just because the people who are going for the exam in coming maybe 1 week or 10 days, I have done in detail. Maybe you will find some of my discussions in which I have prepared somehow, or I have used to make slow down. So one by one, I have discussed almost all the topics. Okay. So I will request all of you to have a look on the channel, and you will, if you want, if you think that, because my way is not to give you a, you can say, a spoon feeding. Okay, so you will find a number of discussions which I have done in respiratory system. I have discussed, believe me, each and every point, even physiology I have discussed in detail. So here you can find out the discussion and the basic concepts and the basic sciences: asthma, COPD, hypercarbia, hypoxia. Like I have discussed even the hemoglobin oxygen transport, smoking. I have discussed a number of topics before. Similarly, one important point I will tell you, that the preoperative assessment with reference to respiratory system is very, very, very important. Okay, because whatever topic they are asking you, if you have a good grip on the anesthesia, manage how you are identifying the risk, so that will become easy for you. So please, I will highly request you to have a look on this playlist. Okay, so here I have discussed about the pulmonary investigation, the cardiac investigations. Okay, and this is the concept of perioperative medicine. If you have a good concept of how to identify the problems, how to optimize the problems, and how to manage each step. Because in the exam, they will not ask you, tell that this patient can go to ICU, this patient, how will you manage? They are expecting which fluid you will give, which analgesic you will use, which induction agent you will use, which muscle relaxant they will use. They will not ask you each and everything. You are supposed to cover all ends. Like I told you. Okay. So I have told, because the conceptual things you never forget, the cramming thing you forget. The pathology you can forget. Like you asked me exactly, I am not able to explain to you pig puffers or blow bloater, because I am a human being. I am not studying. The last exam in which I appeared was in 2016, and since then I am just trying to have a contact with all of you, just because of these sessions. Okay, so thanks a lot. Inshallah, tomorrow we will try to have a good round of uh, regional analysis. Okay. So I again, thanks for honoring me to join the discussion. Share the message, clear your concepts. If you have clear concepts, your exam will become very easy. Okay. And I will be very happy to answer any of your questions. I will try to answer you on the WhatsApp. Okay. So thanks a lot for joining. And inshallah, tomorrow we will meet again. For regional tomorrow, please compare and contrast tab block with quadratus lumborum block. It's been asked in Vivas nowadays. Since it's new intervention, it's not new intervention. Actually, I can answer you some of that. The quadratus lumborum block is going a little lateral, a little posterior. So the advantage is that it will cover the visceral component as well. Tab block is a mesquite block. It does not cover the visceral component. So this is the answer they want you to tell you. Another important block, which is, I love it. I have, rather you can say, I have almost stopped using tab block, because erector spiny block is an excellent block, which covers, give a very good uh, coverage as compared to tab block. Because tab block, a number of times you are giving a very high volume, and it is only covering the somatic component. It is not covering the visceral component. Okay. So I hope you answer. In regional anesthesia, actually, I have discussed a number of time, because regional anesthesia is my interest, topic of my interest. So like I have done a lot of sessions, but my main discussion will be again the basic concept and how to choose a regional anesthesia technique which reference to different various surgeries. This will be our main topic tomorrow. Okay. So thanks a lot, all of you. Bye bye. Uh, if I'm not able to answer any of your question, please do contact me on WhatsApp. I will try to answer to you in WhatsApp. Okay. I will try to read and I will answer. One of the question was about pink puffer and blue bloaters, which I always forget. One question was about autopee. I will try to recall the concept and I will try to explain. Okay. Bye bye. Do drop a message on WhatsApp. Yeah.